Hi, my name's Jamie Layland. I'm a cardiologist that works at Peninsula Private Hospital. I have an expertise in interventional cardiology, I have a special interest in research and the management of patients with chest pain. So coronary artery disease is a chronic disease. It's a disease of atherosclerosis build up in the vessel wall. It starts with damage to the endothelium, which is a layer of cells inside the vessel wall. The endothelium gets damaged, and then we have increased permeability of the wall. We then get large proteins which can be deposited in the vessel wall and attract inflammatory cells. These inflammatory cells swallow, if you like, the proteins, and we get things called foam cells. When we get the development of foam cells, smooth muscle cell proliferation, and the development of a plaque, and that's how we get atherosclerosis. The natural history of atherosclerosis is generally one of progression, so it's really important to identify it and treat it because it has this natural tendency to get worse over time. There's really no difference other than the fact that in females, the symptoms of atherosclerosis tend to occur later on, usually 10 years later than their male counterparts because of the protective effects of female hormones. But the actual physiology or the pathophysiology of atherosclerosis is the same whether you're male or you're female. But females have different hearts, their anatomy is different and the structure is different, so females can manifest in different ways. In general terms, in patients with atherosclerosis, the risk factors for atherosclerosis are 1, increasing age, 2, tobacco use, 3, history of diabetes, 4, family history of ischemic heart disease, 6, hypertension, 7, hyperlipidemia, 8, obesity or having a sedentary lifestyle. They are the traditional risk factors for atherosclerosis or coronary artery disease. There are more novel risk factors such as chronic inflammatory disorders such as rheumatoid arthritis, but there are sex-specific risk factors that we look for. So particularly in women, we ask for a history of gestational diabetes or a history of gestational hypertension. These two are important risk factors for the later development of premature coronary disease. Other things we ask for is a history of premature menopause. For obvious reasons, you won't get the protective effects of the female hormones and you will present earlier. So we do ask for those sex-specific questions when we're doing a risk assessment looking for risk factors for coronary artery disease. So most patients with coronary artery disease are asymptomatic. So we have this asymptomatic coronary artery disease which is very prevalent in the community. But obviously, one of the feared manifestations of coronary artery disease and atherosclerosis is a heart attack. We always worry about that in our patients. And so the traditional presenting features of coronary artery disease, whether you're male or female, is chest pain. Traditionally or historically, we used to think that females present in atypical manner. So nausea, dizziness, lightheadedness, etc. And that's kind of been the mantra in the last decade. But recent evidence from trials from Europe has really challenged that notion. And now we know that females present with typical symptoms. So they're just as likely to present with typical symptoms that males have. So that would be chest pain radiating to the jaw and to the arm and to the back. That is just as common in a female compared to a male. So they're equally as common. However, females are more likely to have associated atypical symptoms. So they may have palpitations, they may have nausea in addition to these chest pains. There are other less common atypical symptoms that can occur, but these are equally common in males and females. When a female presents with chest pain, obviously the most important thing we want to make sure that they don't have, obviously I'm biased because I'm a cardiologist, but the most important thing we want to make sure they don't have is a heart attack. So that is fundamentally the most important thing that we need to do. But there are other reasons for chest pain in females, such as PE, inflammation of the heart, etc. However, there are conditions which can manifest with chest pain, which can cause heart attacks, which aren't due to coronary artery disease, and these are much more common in females. These include things such as spontaneous coronary artery dissection and newer conditions that we're more aware of in recent years called ENOCA and MINOCA. So Inoka and Minoka really refer to ischemia in the absence of major coronary artery disease. So traditionally when you have a heart attack, you have a big kind of blockage due to clot in your artery, we balloon it, open it, put a stent in it, and generally patients feel better. In conditions such as Inoka and Minoka, which are more common in almost exclusively in females, we don't tend to get these blockages. So we get the same manifestations, the same signs, the same blood test results. However, we can't put stents in to fix things. So GPs and specialists need to be aware that just because an angiogram is normal or there's not any coronary artery disease, it doesn't mean this patient isn't having angina or is at risk of having adverse cardiovascular events. So in terms of how we treat patients with coronary artery disease, obviously the mainstay of treatment is lifestyle, diet and exercise. So fundamentals to the management of anyone with a diagnosis of coronary artery disease. And in terms of specific therapies, we know that from registry data that even when females present with similar symptoms, signs, findings, they're less likely to receive guideline-directed medical therapy. So that's really an area of opportunity for us as clinicians, you as GPs, nursing staff, etc., to try and improve treatment for females because they are getting undertreated in the community. So in that situation, when you have someone with chest pain, it's best to ring an ambulance and get them seen in the emergency department to receive prompt treatment. However, you may have someone who has a history of chest pain or who comes to you having had chest pain some time ago, then the best way of treating those patients is to refer to your local cardiologist.